So welcome to another installment of our series entitled The Power of Pivoting, Managing Through Crisis, a series of discussions with key HSS personnel concerning how we have responded to the COVID-19 crisis. I'm Dr. Ronald McKenzie, an internist and rheumatologist at Special Surgery. So today I'd like to introduce Lauren Wessel, who's a PGY5, which is to say a physician in her final year of her orthopedic training. Who was really chosen because of the leadership she's demonstrated within her peer group in this very unprecedented time to share some of her experiences working as a different kind of physician than she anticipated she would be in this final period of her training. So welcome, Lauren. So Lauren, tell us a little bit about what this has been like.
So there have been a lot of phases of transition as we've gone from the first reported COVID case in the United States to it really coming to New York and then being a true quarantine setting. So I think there have been phases in how we've dealt with it accordingly. Really the first phase has been when we closed down our elective surgery practice, only focusing on essential surgeries, and as a residency that forced a real switch from people being on elective rotations to really covering needs with regard to this COVID pandemic. So, the first switch was shifting all of our residency staff from those elective services to service lines that were still busy and still in need of staffing during this time of crisis, and also keeping team setups for those resident rotations whereby people could have a time to decompress after a set of shifts and self-isolate to see whether they became symptomatic. That also worked to keep teams together so that there wasn't a cross-contamination between teams should someone develop symptoms. So that was really our first shift. We split teams between trauma rotations, our Memorial Sloan Kettering service, our VA hospital, which is still running. And then the next shift from that point was really thinking about, as we opened up HSS ICUs and had COVID positive patients needing medical care here, large set, about half of the residency pivoted to covering ICU roles in those hospitals. So we cover both ICU roles at HSS here, where we've been taking patients overflow from our neighboring hospitals, which don't have capacity for them, as well as covering at the Queen's Critical Care Service. And those were all really volunteer basis, people who came out of their orthopedic rotations to really help support patient care during this time.
So it's clearly been a sort of total disruption of life as you knew it in residency, I suppose, for the entire group. And how has how's the collective response been?
So, I think the response has been an overall really impressive one. Everyone really wants to step up and help in the ways they can. And I think obviously while there's uncertainty about orthopedic training at this time and people who are focused towards applying for fellowships or otherwise, I really do think that as a whole, our residency has felt that this is an opportunity to gain skills that we would never otherwise gain, be it leadership, be it being flexible and pivoting. This is a type of situation where one may never see this type of reorganization and rapid shifting again. So all of the things that we're losing in our orthopedic training, right now it's been about a month. It's a month of 5 years. And so for all the couple of cases we might be missing, this is a really critical time that we come together, work on our teamwork skills, our leadership skills, our flexibility, and kind of understanding communication. I think a huge task and skill that's been challenged during this is establishing clear lines of communication and having those be really open through this crisis, especially in a time where you can't be in the same room as many people because of social distancing. All of our prior conferences were canceled. We've really transitioned to a virtual learning, and also having these virtual meetings online to reorganize each time that we do it. So I really think it's challenged us in different ways, and I think we'll come out more effective leaders and communicators for those reasons.
So do you feel that the response of the institution has been really supportive of the trainees still achieving their goals and understanding of the complication that this really presents to many of them?
Yeah, I think as residents, we're very fortunate. Again, this is one of 5 years, and we have relationships with the attending faculty members here that persist, or started before this epidemic and will persist much long after the epidemic. And the way in which I think the residents have responded has been well supported by the faculty members. And I would say that all of the feedback we've gotten is that this is a group of residents that the faculty won't forget because of our being open to responding and moving and being quite nimble in that way. And we are working, I came down from an ICU shift to kind of answer some of these questions, but it should be said that there are 3 attending orthopedic surgery faculty members sitting right next to us in the ICU, helping put in orders, helping change lines, helping do vent settings. So I think we're all in it together, and I think the support has been tremendous.
And how do you feel, my understanding is that the residents and fellows have really stepped up in terms of the educational component of their experience here. And when you consider that the sort of exhausting nature of the work to yet still commit to that is really quite impressive. Can you tell us a little bit about how that's conducted?
Yeah, I think there's been a great support from academic training, making sure that we have regular video conferences, and a list of those conferences is circulated for all the residents and fellows to have access to each of these educational conferences. And the truth of the matter is, the residents and fellows have certainly stepped up to make sure all of these clinical needs are covered. But in the setting of this infectious disease, obviously there is a time for self-isolation and quarantine after each shift. So about half of the residents or fellows are likely home at any given time, and those people are both consuming and producing academic materials to make sure that everyone keeps up with their education and make sure that they get the orthopedic content that they need to keep progressing.
And on a personal level, I mean, how stressful is working in this kind of environment? And I'd like you to comment a little bit about even personal health concerns, or amongst your group, health concerns about others.
Yeah, I think that's changed over the course of the pandemic. I think a month ago, if you would have asked that question, there was a lot of uncertainty. No one really knew what was going to happen in the course of the disease, the contagious nature, whether, PPE. You've seen a number of grids come out with amendments to the PPE policy, and that's as we've learned more. So I think with uncertainty, there's a lot of fear, and I think that's natural. I think that happens kind of in all settings with this. But I guess getting back to your question, with regard to safety, I think now being on the ICU, knowing what we know, having had a month plus of experience with the disease, we feel that we have adequate PPE, we're well supported, that we would never be asked to go into a situation where we felt uncomfortable. And then in addition to that, the personal stress, I would say, is minimized because of the extraordinary support of, for example, the attending anesthesiologist, the critical care staff. You see nurses who I commonly sign out to in the PACU, who typically manage, post-operative ambulatory orthopedic surgery patients, and they're helping out. They're going into the COVID positive patient ICU rooms, changing vent settings, doing a number of things that are definitely outside of their comfort range as well. And I think it's just a part that it just shows that everyone is pitching in. And we're all a little bit out of our comfort zone, but knowing that we're all there together definitely decreases the stress.
So you mentioned something about comfort zones. There's a number of areas where that might come up. So, for instance, finding yourself as a well-trained orthopedist in a situation where you're now in an intensive care unit, have you felt at times that the decision-making fell to you in domains that you were uncomfortable with?
I definitely feel like we have, again, extraordinary support from our anesthesia team. So I think I can speak for all of the orthopedists who are staffing the ICU right now. If there's ever a question that I am uncertain of or doubtful of, I have a person who is a text away that, our perfect serve, I guess, is a form of text, but so the anesthesia NPs who staff the critical care unit at HSS, throughout the year otherwise are readily accessible on perfect serve, or if you just walk around the corner, you can find one of them usually. And then the anesthesiologists are very accessible. You just walk by their office and ask. We're directly managed by anesthesia fellows who usually sit with us. So among those kind of three sets of people, I've literally never had a question where I felt uncertain, like a decision was falling to me that I couldn't, or that I had to answer that I was uncomfortable answering. So I think everyone's been very receptive and knowledgeable of the fact that we are not anesthesiologists and we have not done internal medicine since medical school, and we've had extraordinary support.
What about the stressful circumstances that arise in the critically ill patients who are potentially going to have cardiac arrests or require, well, I suppose most of the patients you're looking after in the ICU are already on ventilators, but there are then decisions to be made after prolonged periods of ventilation about potentially extubating people as a sort of terminal event, or moving on to putting in tracheostomies and so on. That must be pretty prevalent.
Yeah, so I would also say, and this, again, these are all viewpoints from the HSS ICU because I haven't been working with the Queen's critical care unit directly, but at least within the HSS ICU, there are a number of anesthesiologists who are either partaking in other clinical, because there are still essential surgeries going on, so either staffing those on an alternating basis, or anesthesiologists who have risk factors that are keeping them out of the hospital right now. And those anesthesiologists are helping to be the point people for each of these families, and actually interfacing with our team and going through the chart and then calling the patient's families every day to talk about the possibility of a terminal extubation, a tracheostomy, to understand their goals of care and their current clinical situation. So that's been a huge source of support for the critical care team, so that we can focus really on the patients who are on the floor that day, if they're active, if there are things that need to be changed. It kind of unburdens the clinical team from needing to expend a lot of time with those long conversations, because you could imagine with a full critical care unit, those conversations take a lot of time, and they take a lot of, I think, energy, and that extra support has been enormous.
And we do have palliative care services here.
And they've been interfacing in the same ways.
Well, Lauren, thank you very much.
Thank you.
Well, tell us a little bit about what's going to happen with you after this, like July.
Well, so I'm going to St. Louis for a hand fellowship at WashU in July, starting in August. And after that, I'm doing an oncology fellowship, which I match for on Tuesday, so I can't tell you where that is yet. So I also had to do the whole match process during this.
Well, listen, thanks so much, and good
No
luck.
problem.